Hey, it's Tom here from Running Physio. Thought I'd arrive a little bit early for our presentation on proximal hamstring tendinopathy this evening. We're going to be trying to stream some slides, some video as part of this. So I wanted to come on, check everything's working out okay, and that you can all see me on there. Now, occasionally with these, because we're trying to, stream HD content over the internet, we do cut out a little bit. So I apologise if there's the odd break in play here and there, but I'll try and make it run as smoothly as possible. We also have got a pre-recorded version of this too, so hopefully people will be able to watch it later and we'll be able to share it with you. So, a few of you arriving now, welcome. Nice to see everybody. Do ask questions and things, particularly as we go through the presentation. I'll try and stop and answer those when I can, or if not, I'll make sure we get to those at the end. There should be a link as well for you in the text. Let's just have a quick look. Yeah, there should be a link for you there in the text where you can sign up to our newsletter. You'll also get access to our new lateral hip pain videos that are coming out very shortly, and we'll tell you about our next case presentation, which is hopefully going to be next week for World Physiotherapy Day. So lots of new content and things coming out for you to get involved with and join in and enjoy with us. So we'll just leave it a minute or more, just so we're giving people the last second or two to come in. I know some of you will be joining just on the dot of 6 o'clock or just after. We just chatted to a lovely group over on Facebook, so that was good chatting to them, good questions and things. So I look forward to hearing from you guys and the questions you have as we go through this presentation. Good stuff. Now, talking a little bit about proximal hamstring tendinopathy before we dive in. Now, it is a problem that's quite close to my heart because I had proximal hamstring tendinopathy while training for a marathon back in 2013. And it really stopped me in my tracks. Honest Physio's there. Good stuff. I'm expecting some cartoons about this later. Man's very talented at his cartoons. Definitely one to follow. So yeah, I had proximal hamstring tendon problems back in 2013, and they really stopped my marathon training in its tracks. In fact, that year I wasn't able to complete my marathon because of this proximal hamstring tendon problem. And what surprised me at the time was just how little research there was out there to guide our management of proximal hamstring tendon problems. So I went off then and did a lot of research into it, which I learned an awful lot from, and then in 2016 published a narrative review of the management of proximal hamstring tendinopathy. So I learned an awful lot about it. What I tend to find now is that I see a lot more proximal hamstring tendinopathy as a result, because once you've published research in an area, people recognise it's something you know about, you'll often find patients seek you out. We've had some travelling all the way across the country to see us to get a second opinion on proximal hamstring tendinopathy. So I thought it would be good to get a case study together and talk to you about kind of real world management of it, really, what we're actually doing in clinic here, and how we're applying our interpretation of the evidence, because there isn't a great deal of evidence out there, and so there's no right or wrong way of doing it. But I thought it'd be useful to show you kind of a real world example of how we do it. Now, let's talk a little bit about proximal hamstring tendinopathy pathology, and then we'll dive in with a case study. Now, we think that proximal hamstring tendinopathy is an insertional tendinopathy. We think that the hamstring tendon is compressed against the ischial tuberosity when the hamstring is stretched or the hip is flexed, but also in sitting, because we think there's direct compression of the hamstring tendon occurring there. So that shapes our management, because particularly in the early stages when it's quite irritable, we try and reduce those compressive activities because they're thought to be especially provocative for the tendon. So that will involve taking away stretches, taking away deeper squats and lunges, taking away deadlifts potentially for a period of time, perhaps trying to minimize sitting, particularly in irritable cases. It also shapes our assessment. So a lot of our assessment is around seeing what happens when we test the hamstring in positions where there is compression of the tendon, and seeing how it behaves under load. Now, while we talk about the role of compression and things, I think we've also got to be mindful of the effect these words have on our patients, because that word compression is quite physical and it's quite suggestive of damage. So it's not one I tend to use with patients very often now. When I'm asking them to maybe modify their activity, I'll be saying, well, let's see if we can reduce the things that irritate your tendon at the minute to allow it to settle. So let's reduce the sitting a little bit. Let's reduce the stretching. Maybe let's replace the deeper squats and lunges and deadlifts with something else for a little while to let it settle. But in time, our aim is going to be to get you back to what you want to do. So we're not trying to create fear and avoidance of activities like sitting, which is completely normal. I think around about, most of us sit for around about 6 to 7 hours a day. So if you start to suggest that's damaging for people, it's going to cause a problem for a lot of people. So the problem is some people are hearing that message that sitting and things is bad, that compression is bad, and they're now avoiding those things altogether. So I know some people that don't sit even to eat because of their proximal hamstring tendinopathy. So you can think about the impact that will have. Their social life's affected, their work life is affected. So we've just got to be careful we don't overdo it in terms of how we sell that message of compression. So let's tell you a little bit about our case study. It's a 29-year-old male runner called Alex, who's come to see us for this persistent right-sided proximal hamstring tendinopathy. We're going to try and include some slides as we go here. So this is a bit of details about his history of present condition. So his proximal hamstring problem began in 2012 when he transitioned to track work. So he was increasing the intensity of his training and he found it was sore at the end of a particular session. It then worsened significantly following a race and he wasn't able to continue running. In fact, he was out of running for a year at that point. So it had a really big impact on him when it first presented. He's had lots of physio since then. He has done some loading exercises, but without really much consistency or progression. He's also tried acupuncture and he's had an epidural, which sometimes happens with these types of problems because we think it might be coming from neural tissue for a lumbar spine. So often these things are tried, but it didn't really create much long-term change for him. He's had an MRI back in 2012, but nothing abnormal was detected. Now, that's not that unusual either with proximal hamstring tendinopathies and with tendinopathies in general, because as you know, the connection between pathology and pain isn't especially clear. So you can have pain even without changes that are clear on an MRI. Now, as he's presenting now, his symptoms are episodic in nature. They tend to flare up if he tries to push his training on at all. So it's limited how much he's able to run. And they've been particularly bad in the last couple of weeks in response to him pushing his training on a little bit more. So that's his story to date. He's coming to see us during one of these flare-ups, having pushed his training, and he wants now to see some consistent improvements, not to have this frequent flare-up and relapse that he's having, which is very, very common in tendon pain. So we've got to try and plan a route forward together. Now, looking at his pain chart, he describes this pain in the base of his buttock there as intermittent hot pain that's about 6 or 7 out of 10 on the pain scale there. And it does behave like tendon pain might be expected to. So it's there at the start of a run, but it actually warms up as he continues to run, which is common with tendons, only then to be worse after the run, particularly with longer runs, with faster runs, or with hill sessions. Now that would make sense because those faster runs and hill running are also going to be more challenging for the hamstring tendon. We think as you run uphill, for example, that you flex the hip more and you need to work the hamstrings more to drive yourself up the hill by extending the hip with the hamstrings and the glutes. So the hamstrings are working harder and they're doing it in a position where there's likely to be some compression. So hill running is particularly provocative and it was a big part of the development of my symptoms. And as with other proximal hamstring tendinopathies, his symptoms are also aggravated by prolonged sitting. So it is fitting that picture at the moment. But we also want to make sure that we ask about other areas. So we've checked that he's not got any back pain, he's not got any hip or groin pain, there's no spread of symptoms down the leg, there's no pins and needles, no numbness. We want to try and clear areas as much as possible with this as part of our diagnostic process to be sure or at least have a good idea of what the diagnosis is. In terms of past medical history, he's fit and well. He's a young guy, as I said. He's only 29. He's fit. He's active. He has had a little bit of low back pain when he was growing up, but that's long settled. And in his past medical history, he doesn't have any features that we might expect to affect the tendon or its ability to adapt to exercise. So things like altered thyroid function or diabetes, they may well influence the tendon's ability to adapt to exercise. Changes in the lead up to the menopause also can affect the tendon and its ability to adapt to exercise. So our past medical history is going to be asking about those things alongside our kind of routine questions to see if there's anything else influencing the tendon's health. He also doesn't have any signs or symptoms consistent with inflammatory conditions, which can also present with tendon pain. So he doesn't have prolonged early morning stiffness. He doesn't have joint pain and redness. He doesn't have changes in skin or with digestive function or any of those other features that might be present with spondyloarthropathies, inflammatory conditions and things, which can sometimes drive tendon pain. And these are important things to find out in the early stages to make sure we're not missing something else that's driving the symptoms here. So his past medical history is essentially clear, good general health, nothing here that we think is going to influence the tendon too much. Likewise with his medication history, he's not on any medications, he doesn't take anything. He's not been on steroids or statins. He's not been on fluoroquinolone antibiotics. These are all things that are thought to influence the tendon's health. And I've seen a couple of cases recently where people have had tendinopathy in reaction to certain antibiotics, and they can have quite a profound effect on people. So again, these are the things that we want to ask routinely in our assessment to make sure that we're not missing any factors that affect the tendon health or also diagnosis of the problem. We have his social history here then. He's a studio manager, so he's sitting a lot, which can be a factor, something we might need to reduce if it's provoking his symptoms. And he goes to the gym 2 or 3 times a week, but he doesn't tend to work the legs. And this is, he may do a bit of calf work, but this is something, again, we quite often see with lower limb injury. When people have an injury, they often stop doing gym work on the legs because they feel it might be damaging. When actually, often we recommend the opposite. We suggest that they build back into their normal gym routine because it can be a helpful part of their rehab. He normally races 800 and 1500 meters, but at the moment his current run tolerance is around about 10 minutes. And what I mean by that is how much running he can do with minimal pain without a lasting reaction the next day. And it's important to try and establish that because that helps us to decide what training he should be doing at the moment. Now, hopefully on your screens, you should be able to see his weekly schedule on the right-hand side of your screen. Here we can see he's got a really full schedule. So Monday he's going to the gym and then he's maybe doing some circuits as well. Tuesdays he's got intervals on the track or on the hills. Wednesdays he's running in the morning and then gym in the afternoon. Thursdays it's interval sessions at the track. Friday another gym session. Saturday a race, and then Sunday a long run of approximately an hour. Now there's no rest in this schedule at all, so that's going to be a factor. We can also see there's a lot of high intensity training, which to some degree you're going to need if you're competing over 800 or 1500 meters. But if we look particularly at Tuesday, Wednesday and Thursday, we've got consecutive run days, which tendons do seem to find challenging because they need time to adapt. We've also got a gym session in there, and 2 of those run days are quite high intensity. So this may be part of the reason why he's tending to get these flare-up in symptoms, that his weekly structure and how it's progressing may well be proving too much for the tendon. So as he returns to it, it just irritates the tendon and he has a flare-up in his symptoms. So our early advice might be around saying, well, let's change his schedule a little bit, at least in the short term. Let's try and make sure that we keep some running going at a manageable level, but perhaps we run every other day, so we've got a day in between those run sessions where the tendon's got a chance to recover. And we'll often combine that with maybe 2 or 3 rehab sessions a week on those days that the person's not running, so we're not asking that tendon to cope with a lot of load all at the same time. So very important in these early stages to get the load management right, to try and bring it to a level that Alex can cope with to allow the tendon to settle. And if we don't do that, it's very, very hard to settle tendon pain if we're continually loading a tendon beyond what it can cope with. So some early advice for Alex there on load management, changing the structure of his week and bringing it down to a manageable level to let his symptoms settle. Now, we did our objective tests. We found that actually we looked at lumbar spine and hip range, a full pain-free range in the lumbar spine and the hip. Important to do this if you're working with people with proximal hamstring tendinopathy. Take that step in the early sessions to assess their range in the lumbar spine and in the hip. Make sure we're not looking at a problem that's being referred from elsewhere. One of my favourite tests I tend to do here if I'm suspecting proximal hamstring tendinopathy is a resisted knee flexion at 90 degrees of hip flexion. So we're trying to work the hamstring in a position where there may be compressive load on the tendon. So we usually do this with a patient in supine. We flex their hip to 90 degrees and ask them to dig their heel down into the hand and see if it brings on their symptoms. If it doesn't, we might then take them up into more hip flexion positions or progress them onto other loading tests, perhaps going into deadlift type positions or even single leg deadlift positions to try and progressively load that tendon in potentially provocative positions to see if it brings on their symptoms. Now, in Alex's case, we brought on his symptoms with resisted knee flexion at 90 degrees of hip flexion, and it brought on his specific symptoms at that kind of point in the base of his buttock. So that to me is starting to add to the rest of the information to say it probably is a proximal hamstring problem. We don't have a great deal of research, unfortunately, on the specificity and sensitivity of these tests, though, so we do need more about diagnostic accuracy there. Now, one of the potential differential diagnoses here, other than referral from lumbar spine or from the hip or from neural structures, is ischiofemoral impingement. Now, there is a test that we can do for this, which tends to take the hip into extension. Now, this slide's adapted from Martin et al. The test involves extending the hip but keeping it fairly neutral in terms of ab and adduction and seeing if it recreates that kind of posterior thigh and buttock pain. If it does, it may be more consistent with ischiofemoral impingement, which is a condition that's more commonly provoked by extension of the hip rather than flexion, and that allows us to separate it quite often from proximal hamstring tendinopathy. Now, during our assessment, we also want to identify his rehab needs. So we will look at things like balance and control, at range of movement, but also at strength. And in Alex's case, we assessed him with a handheld dynamometer. And we discovered he was weak in his right glute med, adductor and hamstring muscles compared to his symptom-free left side. So that suggested that they may well benefit from some rehab. There are problems with comparing to the good side because actually sometimes in tendon studies they find bilateral weakness even with unilateral symptoms. So it can be useful if you've got access to data, sort of normative data, to see roughly where someone would compare to normative data where such data exists. Now, other tests in terms of range, one thing that was perhaps a little bit lower than we might expect, ankle dorsiflexion of around about 30 degrees bilaterally, which he said was normal for him, but I thought wasn't really particularly relevant in his care. We think about the hamstring when it's actually working its hardest is during the swing phase, terminal swing, where we're not actually in contact with the ground. So I'd struggle to reason through how slightly reduced ankle dorsiflexion is going to influence the load there in that position. So my initial thoughts then, I'm thinking so far that its symptoms, the pain location and its behaviour, the tests that we've done so far, the fact that lumbar spine range, hip range are clear, our other tests are negative, I'm thinking it is likely to be a proximal hamstring tendon problem. And I'm thinking that part of the reason why it's not improved so far is because there hasn't been adequate load management, and there also really hasn't been structured and progressive rehab. We've not found a way to build up the strength and capacity in the hamstring and the rest of the muscles to reach the level that Alex wants to in terms of his running. So our treatment approach here then needs to be to help him understand his pain, to bring the training down to a manageable level to let symptoms settle, and then try and improve his strength and improve that tendon health with a progressive strengthening program. And that's what we did then as part of our first session. We discussed our findings with Alex and tried to explain it to him in a way that he could kind of understand, because you want people to leave that first session with an understanding of their pain so that he can see that actually the tendon, is strong and healthy tissue, but if we overload it, it reacts to it and becomes sensitive. So it's important that we don't increase the load on it too quickly. And that actually if we do some strength work, it can improve its ability to manage load, and then we can gradually progress him to where he wants to be. So we're able then, with him understanding what's going on, to form a rehab plan together. And that's what we want to be able to do here, is plan with the patient rather than for them, to try and get him towards his goals of racing 800 and 1500 meters. We also talked about expectations in this early session, particularly that's likely to take time to improve and flare-ups are likely. And we brought in 3 exercises for him to do. Now, I've got the 3 exercises listed here. We have isometric prone hamstring curl, which I think I've got an image for you here. Really simple. We're looking at trying to get the hamstring working here against some resistance. So here we've got working against a TheraBand, but if you've got a solid surface to push against, even better. Because you find sometimes working against something like TheraBand, it can get a bit shaky with the exercise. So if you've got like the underside of a bed or something you can push against, that is even better. So we brought in a prone curl here, and also a single leg bridge that I'm sure you'll all be familiar with. Now the prone curl was isometric because that seemed to help in the session to settle some of his pain with our loading tests. So we had an isometric prone curl, then we had a single leg bridge focusing on starting about 3 sets of around about 15 rep max to start with. So the maximum kind of load with that he can manage about 15 reps. And then we also included our supine leg curl. Now, if you're not familiar with the supine leg curl, we do have a video for this, so let's just pop this slide away. So here we have the supine leg curl. We bridge, we try and get the hips nice and high, we roll the skateboard out, and we roll it back again, keeping those hips high throughout. We think the eccentric action is actually happening as we roll that skateboard out. So from here, rolling out, the hamstrings have to work eccentrically to control that skateboard. And it does look easy, but if you try it, it's actually a real challenge for the hamstring complex. So often people need to start with 2 legs before progressing on to more single leg work. So we brought that in there as part of his rehab for those early stages. Now, something I want to point out to you is that we're trying to restore the hamstring's function, and 3 of the key things it needs to do is it needs to flex the knee, it needs to extend the hip, and it needs to work eccentrically. So that's why within these 3 exercises, we've got one with a knee flexion bias, which is a prone curl. We've got one with a hip extension bias, which is a single leg bridge. And we've got one with a more eccentric bias, which is our supine leg curl, to address those 3 functions. Now, during our research in this, we were having a look at some of the exercise options, and this included looking at the EMG studies of various different hamstring exercises. Now, EMG studies do have their limitations. Let's get that out there straight away. But this study by Zebis et al. Is quite useful because it gives us an indication of when the hamstring's active during various different exercises and how much hip flexion we've got at that peak activity. So of our 3 exercises, we've got prone curl that I've highlighted here. It suggests there seems to be quite a lot of activation here in semitendinosus and biceps femoris, if you look at those 2 left-hand columns. And this is happening at around about 10 degrees of hip flexion. So it's going to hopefully be working the hamstring in a position where there's not a great deal of hip flexion. Supine pelvis lift, which I believe is similar to a single leg bridge, or same as single leg bridge, again, seems to be working the hamstring, but with very little hip flexion. And the same's true of the supine leg curl. Quite a challenge for the hamstring complex, but doing it in a position where there's very little hip flexion. So that's why we've chosen these 3 specific exercises to start with, because they're ways in which we can improve the hamstring's function in the flexion, hip extension, and eccentric work, but in positions with minimal hip flexion. So hopefully it will reduce the compressive load on the tendon. Now, geekery aside with these things, ultimately, it does come down to what you find the patient can tolerate. So we can have these theories, but what we did with Alex was spend time within that session trying those exercises, trying to load them at the right level, checking how they were in terms of pain response, and then giving them the chance to go away and work at them. So that was session 1. Also, bottom of this slide, important to point out that as part of this, we talked about reducing his training to a manageable level. So starting off, bringing it back down to 10 minutes. So we're combining that with hopefully improving his capacity through strengthening up the hamstring. So then we brought him back a couple of weeks later for session 2. And this is, to be honest, what I tend to do. I'm not someone who brings people with tendon problems in 2 or 3 times a week. In fact, I'm usually bringing them back every 2 or 3 weeks. And it's because tendons take time to change. And also because, being entirely honest, I've never found hands-on stuff brilliantly effective for tendon pain. So it doesn't seem to be justifiable to bring them in repeatedly for something that's not likely to help. We give them the right tools and allow it the time to improve. There's also a tendency, if you're seeing someone 2 or 3 times a week and things aren't changing, which they won't really with tendons very frequently, it's going to become quite quick that you'll get despondent, and so will the patient if they've already been to see you for 6 or 7 sessions before anything's starting to change. So it's a good idea, I think, to spread those sessions out a bit. So session 2, a couple of weeks down the line, symptoms have already settled significantly, but they're still there if he tries to increase his intensity. And we've reviewed his exercises and we've progressed them to include exercises for the glutes and adductors because they were found to be weak. Remember, particularly the adductors are thought to help the hamstring function. They're thought to be almost like a fourth hamstring, particularly in extending the hip from flexed positions. So if we're finding a weakness there, it often helps to strengthen the adductors. The adductors also attach very close to that hamstring origin, so we often want to try and strengthen those up in proximal hamstring tendinopathy, particularly if they're weak. So now his program has 5 exercises in it. Now I must admit this is quite a lot, and normally I would do 3 or 4, but this is someone who likes to exercise, who's regularly in the gym, and was quite happy to do a bit more. So we've got the prone curl, we've kept that in there isometrically alongside the adductor squeeze. And he's doing this with the foam roller between his shins with his legs extended, so lying on his back. So we're working the adductors without a lot of hip flexion. We've also got a single leg bridge that we've added load to. We've placed load across his abdomen, so we're building up to about 12 rep max now. We've brought in side lying abduction, again loaded, so he's getting fatigue at about 12 reps. And we've progressed to single leg supine leg curl, which again is going to be around about 12 rep max. So we're starting to increase the challenge from these exercises because his symptoms are settling. We're testing them in the session with him and he's tolerating them quite well. And we're also talking to him about how he can progress himself by adding load as and when he wants to. So session 2, some new exercises in there, progressing with a bit more load to see how he gets on. Now, progressing to session 3 then. Now at session 3, he's continued to do quite well. Again, we're talking a couple of weeks down the line. He's been able to increase his volume and even increase his intensity a little bit. And this is sometimes the way with young, fit, healthy athletes. They are able to increase a little bit more quickly, but we still need to be a little bit cautious that we don't push them too fast. Now, I'm feeling at this point at session 3 that we've got good rehab exercises in place, that he's got a good handle on how he can progress them himself by increasing the load. Because if we increase the load, we're hopefully going to get more tendon adaptation. So at this session, we've decided together that it would be good to assess his gait. And what we want to see is there anything in Alex's running style that's going to increase the stress on the proximal hamstring tendon? And the main things we're looking for here are overstriding, so landing out in front of you on a straight leg, or lots of trunk flexion, so leaning forward from the trunk. Both have the potential to increase the stress on the proximal hamstring tendon, although it's again an area that hasn't been studied in a great deal of detail. So have a look at the side view we've got here of Alex running. We've got here both a video of him on the treadmill and overground running. And this is what I'd recommend wherever you can, assess the patient both on the treadmill because you can get good continuous footage, but also off the treadmill if that's their preferred running environment. So we kind of get the best of both worlds here. We can see if they're running off the treadmill actually mirrors running on the treadmill. Now, looking at Alex's style here, I think he's got a really nice running style. He's quite upright through the trunk. There doesn't seem to be excessive trunk flexion. He's a forefoot strike, perhaps a little bit more prominently so on the treadmill, and he tends to make that initial contact with the knee slightly flexed and the shin in a fairly vertical position. He's not overstriding and landing on a straight knee out in front of his body. So I don't really think that from our side view here, we've got too many issues that I would be rushing to address. When we look at the rear view, what we see is that he's quite narrow. So if we draw a guideline roughly down the middle of him, he tends to cross over that guideline. This is again quite a common finding. It may potentially increase the stress on the proximal hamstring a little bit. There might be a bit more stress there with increased adduction. Again, very little research to support this though. But on the whole, I'm happy with his running gait style. I'm not convinced there's anything really obvious here that's increasing the stress on the proximal hamstring. I think his priorities lie more in gradually increasing his training and keeping the rehab in place. So we agreed together that we might come back and review the running gait later, but it's not a huge part of the puzzle. And in fact, there's lots of positives in this gentleman's running style. So we don't want to change it just for the sake of it. We want to change it based on sound reasoning. So far so good. We've had 3 sessions. He's been able to progress his rehab. He's been able to progress his training. All sounds a bit too good to be true. And actually it was a little bit, because session 4, he presented with a bit of a flare up. Now, he presented in session 4 with some low back pain and buttock pain on the right side, which he thinks partly was because of an increase in training, but also because of various shenanigans on a stag do. Now, what goes on stag stays on stag. So I must admit, we haven't delved into, what happened there. But essentially, he's increased the stress on his hamstring and also on the lower back, which maybe isn't used to this level of intense training because it hasn't built up to this for a while, and he's reacting to it. But when we assessed him, he had full range in the lumbar spine, full range in the hip. He's got no leg pain, no pins and needles, no numbness, no red flag signs. He's fit and he's well, and it's improving with time. So we discuss it and we say, well, this is one of these flare-ups that we talked about. It's quite common as we start to try and push training intensity or volume or frequency for tissues that aren't quite used to that to react to it. And I think that's what's happened here. So we talked about trying to maintain the training at a level he felt was manageable, letting him define that, and to do some gentle mobility work to loosen that lower back off. Unfortunately, it settled very quickly. Now, our plan for this session was to try and progress to include some power work, because his strength work had progressed really well. But when someone presents in an acute flare-up like this, it's very difficult to then progress them onto challenging power exercises. So we agreed to let it settle and review things in a couple of weeks. And that's what we did in session 5. In session 5, his back pain has resolved, settled really quickly. He's managing well, and he's been able to increase his training intensity and volume a little bit further. His strength tests have now improved with our handheld dynamometer testing, and they're equal left and right. And his symptoms are non-irritable at this point. He's now tolerating higher intensity work. He's been able to increase the load through his rehab. And this is the point where we might consider bringing in more power-based exercises. Now, the reasoning process behind this here, the reason why I might want to bring in power exercises is because in his history, he consistently has flare-ups when he tries to push his training intensity. So when he's trying to run faster. And he needs to compete over 800 and 1500 meters. And he needs to be powerful in order to do that. So I think perhaps a missing piece of the rehab puzzle here is that his power hasn't been addressed. And with that, then, we need to be able to improve his speed. Because power, if we really simplify it, is essentially strength plus speed. And that is a simplification, but it tells us that strength is an important part of power too. So as you can see on our little whiteboard here, which is a sort of summary of his plan, we've told him to keep the strength work going and bring in some power work alongside that. So what we've done then is we've reviewed his weekly schedule at this stage. And this is my whiteboard at work. You get lots of scribbles on this whiteboard on a day-to-day basis. And this is what I like to do, to look at the weekly schedule and plan it together with the runner. So we've got the rehab sessions in Monday, Wednesday, Friday, every other day. We've got a run session focusing on speed on Tuesday and longer intervals Thursday. And we've got a longer run Saturday morning. So we decided together that a good time to put the power work in is going to be Sunday evening, to give a nice rest recovery period between the longer run and that power session. And if he can bring in another power session in the week, perhaps before his rehab exercises, he will do. But we've got to bear in mind we've already got 2 quite high intensity sessions in here. We don't want to make changes too quickly. So in terms of power-based exercises, we want to bring in exercises that focus on speed. And in his case, we've gone for plyometric exercise options. So we suggested, first of all, he brings in some heel hammers. Now, what you want heel hammers are, I want you to imagine is you've got the patient lying on their back with their heels resting on a step. They're essentially in a bridge position. So they've bridged up, the knees are fairly straight. We're already in a position which is quite challenging for the hamstring. And then they're hammering those heels down hard into the step as fast as they can for a short burst of 10 seconds. So it's short, powerful isometric hamstring contractions. But because we're focusing on speed and explosiveness, we're going for a short period of time. So maybe three sets of about 10 seconds. We've combined that with some bounding. Now, bounding is a nice option with the hamstrings because it helps us to work on improving both propulsion, but also in the swing phase of running, because bounding is almost essentially like artificially increasing your stride length. And we've encouraged him to focus on speed and length of bounds to really get that explosive, powerful movement as he bounds forward. Again, low reps, about 6 reps, about 3 sets, because the focus on explosiveness and quality, not quantity. Now we've brought that in and said, let's just do this for week 1 and see how you feel. If there's no reaction, week 2 you can bring in chops. Now chops a lot of you will be familiar with. It's in standing, kicking the legs up in front of you and bringing them down very, very rapidly, doing alternate legs. Now when we do these initially with him, we start very quick but in a small range. So he's not kicking up into high feet positions where there's going to be a large stretch on his hamstring. We focus first of all then on getting speed before gradually increasing range. And we bring that into his program. Now at this point as well, we're going to a different phase of the rehab. We're going towards a more monitoring phase because I feel like this athlete has got all the things in place to progress his rehab. He's got good exercise in place and he knows how to progress them in terms of increasing the load or how we can progress them by increasing the speed or explosiveness of his plyometric work. He knows about changing his training, so he's changing one thing at a time, either volume, intensity or frequency, not all at once. So we've got good things in place. He's got a good understanding of his tendon pain and how to manage it. So now I like to kind of give the patient the opportunity to manage it themselves. And we say, we'll monitor things and you can call me if you need me. We often check in every 2 or 3 weeks with a quick email to see how things are going to make sure people stay on the right track. Because I want any session with me to be valuable. For me, I don't really want to bring people back in just to say, keep doing what you're doing, because that's not good use of their time. If we're able to do that via a quick check-in via email, we will. So we've entered into this monitoring phase, and about 2 or 3 weeks later, after this 5th session, he messages me to say he's progressing well, so hopefully in a few weeks we'll be training as hard as possible, so that's a big positive. So that's good news that he's been able to progress his training intensity to this level. And we know this case has been intermittent in nature, so I'm always thinking, well, he's had periods in the past where his pain has settled a little bit. So, are we just looking at that same pattern recurring? Well, yes, that might be true to some degree, but now he's been able to progress his training to further than he has done before, and he's been able to do it without reaction and symptoms. In fact, he's largely symptom-free at this point. So we're going to monitor him and make sure those changes are consistent and help him sort of stay on track as he goes along. So hopefully a nice case study, at least so far, to talk to you about how we might go through that process of assessing someone who presents with hamstring problems, how we might discuss with them around load management, bringing their training down to a manageable level, exercise options we might consider with them, and how we might bring in gait analysis, power-based exercises, and things before going on to letting them manage themselves with a little bit of help from us from afar. Before we dive into the next section, any questions on anything we've covered so far? All good. Okay, feel free to ping your questions in as we go, and we'll come to those. If you haven't had a chance to click on the link and sign up to our newsletter, please do. As I said, we've got new videos on lateral hip pain coming out very soon. We'll have more case presentations coming up next week, so sign up. We'll keep you updated with all the news there. Now, the last couple of things I wanted to talk to you about here was first a little bit of troubleshooting. So if you're seeing someone with proximal hamstring tendinopathy, things you might want to look out for, but also the timeline and other treatment options as we progress. So let's talk troubleshooting first of all. We need to try and get the progression right with our athletes and even with our non-athletes as well. So it's important to try and make sure, as part of taking a history, really get to know the person and how irritable their symptoms are and what their rehab needs are. This is a young, fit, healthy guy who's used to using the gym, so he's been able to go through a quite quick progression through the rehab. We were actually taking about 3 months to get from that initial session to get to where he is now, but other people will take a lot longer, particularly if symptoms are irritable or if there are health factors that are influencing the tendon, like perimenopausal change, altered thyroid function, diabetes, etc. So I think we need to, with each patient, try and make a judgment call about how we progress. And sometimes it is better to go slower and take our time about progressing the load, give things the time that they need to adapt so that we don't get into a pattern of flare-ups and trying to calm the flare-ups down. So important to go slow and get that progression right if it's indicated. We've also got to consider the psychosocial factors, and we did talk about this at the start to some degree, but there's more and more research coming out now that is suggesting that there may be fear of damage in tendinopathy, that psychosocial factors can be a factor here. So I would make sure that we discuss that with patients, that we talk about their beliefs around pain, and we help them to see that the tendon is actually quite strong, quite adaptable tissue, but we need to get the load at the right level. And we might need to talk to them a bit more about improving their understanding of pain and recognizing when other factors around general health, around mood, around beliefs are influencing them, and when that might be more important to address. So a couple of things there to think about. Now, with our tendon rehab, you may have seen recently we produced a bit of a timeline in terms of our tendon rehab progression. And this is something to have a think about because it can take time for tendons to change. So in those first 3 months, there's kind of 3 months we've been working with Alex for, we want to make sure that we're happy that it's a tendinopathy diagnosis and we've considered those differentials. We wanted to make sure that the patient understands the tendon pain and how to manage it. And I think Alex had a good handle on this. We want to advise on load management and graded return to goal activities, which I think we've done well with Alex to bring his training down to a manageable level initially and then build it up. We want to consider those intrinsic factors, age, body mass index, hormonal changes, past medical history, which fortunately for this patient were all fine. And we want to try and determine where they're at the moment, their current capacity, and where they want to be. Then we can provide an individualized loading program that's tailored to their needs and monitor it and adjust it depending on how they respond to it. And there is a lot of that in real-world tendinopathy management. A lot of it involves some trial and error, trying to find the right level and gradually progress. Now, if we're really not seeing any changes by the 3-month stage, then it's important to review our current management. Is the loading appropriate? Have we progressed it at the right rate? Have we progressed it enough? Have we addressed and explored the intrinsic factors? Could there be an alternative diagnosis? This is a time where we may consider imaging if we've not already brought it in the earlier stages, and it can be appropriate to do it in the earlier stages, especially if diagnosis isn't clear. If we've got appropriate management in place, I would say it's fine to continue that management, optimize it as much as you can, but keep the rehab going. But we may want to consider other options. Do we want to get a second opinion from a colleague or someone who specializes in tendon pain? Do we want to consider other options like shockwave therapy, for which there seems to be a growing body of evidence? And also there is some evidence specific to proximal hamstring tendinopathy. Might we want to consider other things like GTM patches potentially, which again, there's been some research from Shalamas et al. Saying may be an option in cases where things aren't improving. And it's only really by roughly about the 12-month point, if we've done progressive rehab over a period of 12 months, that we would then maybe considering surgical options. And again, that opinion is based on recent research from Shalamas et al., their review earlier this year. And I think that is a reasonable approximation of a tendon treatment timeline here. Obviously, it varies from person to person, but it gives you an idea of your options along the way. Now, the last point we're going to make here, as I said, if do fire away with your questions. If you've got anything what you want to add, we're coming to the end of our presentation here. The last point we want to make is that those of you that have read our paper on hamstring tendinopathy, we know that we advocate a 4-stage rehab program. And this is appropriate for a lot of patients, but it's certainly not a recipe. And with this gentleman, we've probably done a mixture of stage 1 and stage 2. So we've included some isometrics, and we've also brought in some heavy slow resistance training. So loading up that hamstring, starting at 15 rep max and going to 12 rep max, 10 rep max and beyond. But we've done all of his exercises without much hip flexion. We could progress him by working into some hip flexion range, particularly if he wants to do more in terms of things like hill running, where he's going to be flexing that hip a little bit more. So that's an option for progressing his rehab further. We have included some plyometric exercises, and I progressed them to this because I felt like actually his needs were more around developing power as a priority rather than bringing in hip flexion range work yet. But that is something we may bring in if he wants to come in and progress his rehab. But I think it's really important with these types of, suggested rehab progressions, they're never a recipe. And I think this gentleman's responded really well to loading out of hip flexion ranges, and he's progressing really nicely towards his training targets. So we can keep those progression options as a plan B if we need to, but at the moment I think it's quite appropriate to keep his management going and give it that little bit more time. Okay, I'm going to sign off very shortly. So any questions before I draw this to a close? If you haven't had a chance to click our link and join our mailing list to find out about our new hip videos that are coming out, please do. As I said, we'll be talking about another case study again shortly. Our mailing list is something we put together so that we can regularly send people updates about the new research as it comes out, with links to those research papers so you can explore those in a little bit more detail. We try and get an email like that coming out every 2 or 3 weeks, reflecting some of the research that's coming out. So if you're interested in running related matters, tendinopathy, gait analysis, strength and conditioning, click that link in the description there, sign up, and you can find out more through our mailing list. Okay, well, no questions so far. Absolutely fine. Do feel free to ask questions in the link. It might be that they're just not showing up on my feed at the moment, but I'll say bye for now. Thank you for joining us this evening. This is the first proper live Periscope that we've done. So I hope it's been useful. I hope there haven't been too many glitches with it. I had 4 attempts at going live with it earlier that all met disaster. So fingers crossed this time it's worked well. I'll say goodbye. Have a nice evening, and we'll speak to you all soon. Bye for now.